So the grades you're seeing right now are your KGA. All right. So your homework, as long as you've done a 78 or above, you'll be okay. That's why the first day of class, I tell you, when you hand something in, do a minimum of a 78 so you know your homework will not fail you. It's one of the most discouraging things for me as a professor to see someone do well on exams and quizzes and don't do homework and end up failing the course because of a lack of homework. It's really, really frustrating to me. So that's why I'm so appreciative with this class. Most of you get your stuff in. I don't have a lot of reminders that need to go out. So I want to thank you for that. It just shows that you're getting ready to be that professional registered nurse that you want to be. So welcome. Okay, this week we got a lot of stuff to do. We are going to do musculoskeletal, neuromuscular. It is that week right before the HESI. So we're going to be going over that. Remember, this week is your week that we're doing reviews. I did mine already, and it is already posted. So you should have that already there. I believe there is one other that I need to post for you, and I'll be doing that when I give you your recording tonight. You'll get the other two recordings that I believe just came up last night. So they'll be there for you. I have sent you, and it will be coming out at midnight tonight, all of your HESI stuff you need. It has the HESIs weeks 1 through 9. It has it's your all your cahoots. It has any handout that I think that can help you. Next Saturday, not this Saturday, week 10, Saturday, I will be doing what I call a HESI Q&A. I do it every term. I've done it for the last couple of years, and I've had very good response to it. And students tell me it really helped them during the HESI, and it made them think, and they could actually hear my voice as the exam was going on. So it's a HESI Q&A. Yes, I've done it before, but what I do is I go back and I look at the HESI, and I don't know questions. They don't show me questions and answers. I don't get that. What I get is a concept. Maybe it's on biliary atresia, or maybe it's on insulin, or maybe it's on intussusception, but I have no clue what they're asking. So what I do is I think of ways to look at that question and what it could be to help you think. And that's what we need to do at this point. You need to think. So that HESI Q&A is for you. There's other ones in my YouTube bank. You can go start listening to them, but every term it's a little bit different because I'm going to see if there's another concept on that HESI, a printout that I get of concepts that were missed. They'll be added to it. Usually there's one or two. I haven't completely fine-toothed it yet, but I'm sure I'll find one or two more things I want to put on there just for you to help you think, okay? So that's what I do for the HESI for you. You got everything you need. So this week you still have a discussion question. Now, know that those discussion questions, I'm starting to answer some of those questions before time. And the problem is, can you answer? If I give you something on a discussion question in the comment after your first Wednesday night post, try to answer it. What the accrediting bodies are trying to do is to see that I'm giving you something to think about a little bit more. Now, yes, I put in every single discussion question something a little bit more about the concept, right? But they want you to answer any questions. So 3 or 4 students I picked that were done. I threw a question in there, make you think a little bit and just answer it. And that will help with the accrediting because yes, we do have great communication back and forth, but they like to see it in paper. Okay, you want to see it in paper? We'll show it to you whichever way they want it, because we all do work very, very hard for your nursing licenses. So chapters 48, 49, we're going to be doing today, musculoskeletal, articular dysfunction. There's a case study that goes along with that. And there is a dosage calculation. You do have your form, it's on your modules. You can either write it or type it, whatever you want, just send it back in. It is worth 1 point, percentage point. So see if you can get that in for me. Some of the questions, it's there just to give you practice. You're going to see a lot of these things. It's just to understand how math is done, okay, in different ways, BMIs and et cetera, you'll see there. So anyway, any questions, just let me know. So let's start with the muscular, skeletal, articular. Now, I love the pictures on the front slide. This is really telling you a lot of different things about bones and joints. Now, the top left one is a Pavlik harness that's put on for hip dysplasia. I'll go more into that. Of course, foundations, you learn about how to use cast crutches, right? Well, then you're going to be learning how now more to take care of casts. What do you need for? What's the assessments? There's 6Ps we're going to go over. And then the bottom left, that's a spica cast. Again, that could be used for that child whose hips are not going to be in place, and we need to give it some more support. And then the bottom right is used all ages, from smaller children all the way up to adults. Adults use it for a fractured hip, but children and at medium ages, it's usually a fractured femur. It pulls the bone out, and it's skin traction. It used to be metal pins we put in, but now we can do it with skin before we get to surgery. So those pictures are great. Just tells you a lot about what's going on. That's why I love pictures. It tells a story. So the immobilized child, you're going to say, children get immobile. How do you get them sitting down? Well, there are children with conditions that are unable to move like we would want. They're either congenital or degenerative disorders. Sometimes they're sick from infections or injuries. And we know that everything we do is to prevent any sort of complications, lungs, DVTs, joint mobility, et cetera, right? So our muscular system is going to get lax. Our skeletal system is not going to get all the exercise, and it's not going to get all the nutrition it needs because you're not eating the way that you should, especially if you're that critically ill. Cardiovascular, I mean, we go through this all the time. Adults, children, doesn't matter. We're worried about our lungs and atelectasis. We're worried about blood flow and venous stasis, and we're worried about blood clots, thrombos, right? So again, how do we prevent all these? Does it make a difference between the adult or the child, how we do it? No. We still turn position Q2 hours. We still do all the physical therapy exercises unless it's contraindicated. So think about that poor child sitting in a hospital room. Let's say they are on some sort of isolation due to some sort of injury, or they have an injury where they can't get out of bed and they can't go out and socialize with the general population. Because that's what kids do. They go out, they socialize, they talk between each other, and it makes what they're going through not as bad. So here's this kid in the room. This child's going to get a little bit upset. They're going to get depressed. They're going to get angry because they're in there. They want to be out with their friends. They want to be in school. They want to be social. And now they're going to start getting aggressive. A lot of times, depending on the age of the child, remember, how do you deal with stress? A lot of the younger kids, it's what we call regression. Start sucking their thumb, becoming incontinent when they're potty trained. All those things you're going to see happen depending on the age of the child. Now, take that child who's needing all of this extra hospitalization because they're long-term care, because let's say they were ran over by a car. Could be, it's happened. So here we have this child in the hospital. Parents are concerned, and there's other children at home and other family members at home. So it doesn't just affect a child. I'm always aware, as being a nurse, when we have children like this, about the families and the siblings, because they are going through a lot themselves. It's not just the kid who's sick, it's the people at home worried about them. And then the children, when mom and dad can't go to that, parents' night, or can't go to see their recital because they're there at the hospital because their other child's having surgery or going through a critical moment. Or remember, it is stressful. Now, what I loved about the facility that I worked at, every single floor was a specialty. Okay. So we had a specialty for neuro, we had a special for GI, special for diabetes, a special for respiratory, et cetera, et cetera. Each floor had parent groups. Okay. These parents would meet every month. And what was neat about them, they would share each other's experiences, whether finding a physician or equipment that nobody could get, or a medicine or something that they needed, somebody found it. They worked together as a team, just like nursing working as a team. These families do too. And what that does, it helps them mentally get through all of this. Always remember there is a parent behind a child, and they suffer probably more than the kid. Okay. Now let's look at traumatic injuries. Kids are all falling down all the time. And do kids normally, especially the younger kids, get up, stretch, warm up, then go out and play? No. They put on their sneakers and they run out the door, and they're nonstop. And there is no time for warm up. We know that's how injuries do occur. Okay. So let's look at mishaps during play, or, sports. Big thing is a contusion. Contusions can happen anywhere. Be careful. Sometimes contusions are more on the inside of the skin, not so much visible, let's say on the outside of the arm or the leg or the finger or anywhere. The problem with contusions is they could be occluding blood flow. So always, any crush injury, any ecchymotic area that looks suspicious, always check neurovascular signs distally. You do that for any neurovascular, any bone break, any injury that's swelling. Neurovascular signs will always be nursing function. Always check that. Now, dislocations. We talked about those good old Downs children and all of the things that goes on with them. Just think about how flexible they are. These little Downs children can take both legs and put them behind their head and sit there, but their hips can pop out. So I would not encourage it, because then the blood flow will go, and, then you have, destroyed heads of the hip, and et cetera, et cetera, et cetera. So dislocations. These can happen when the bone pops out, whether it was congenital, like the hip dysplasia we'll go into in a little bit, or maybe it was an arm. Ever hear of a nursemaid elbow? This is your young toddlers, where you shake them and you pull them by their arms and you swing them around, and it's so much fun. Wee, come on, Nana, do it again, do it again. And all of a sudden the arm goes click and it won't bend. That is a nursemaid elbow. And it happens because of the stretching of the tendons, and they're weakened and they pop out of place. And the arm will lay down there. So they go to the hospital. We don't do anything, no x-ray, nothing. We can see it by the arm hanging there, by what you told us happened. And the physician assistant, practitioner, doctor, not the nurse, but the practitioner, physician, or PA will take the arm, twist it, and it clicks it, and we'll put it in a sling, and it's perfect. We will tell them not to swing them by their arms again. Okay, so the big thing with dislocation is getting it back into the socket, and our always concern will always be disruption of blood supply. Now, sprains and strains, I don't know how many sprains I've had, but they're too numerous to count. I've never had a broken bone, except for one little big toe about 10 years ago. But I don't get broken bones, but I've sprained myself like crazy. And I think they hurt worse than a break. because they swell, they last longer, and the way that they're treated from years ago till today, it's so much better for the ankles. Now, what do we do when we sprain? We stretch the ligaments, tendons, we rip blood supply, blood flows out into the area, swelling occurs, and it's irritating all of the vessels, the tendons, the nerves, and it's painful. That's a sprain. I'm going to tell you how to treat it in a second. Strains are when we do something repeatedly. If you are a bicycle rider, what do you do all the time? You pedal your bike, you pedal, you pedal, you pedal. So you could have strains in your legs. If you're a runner, same thing. Tennis player could be a strain from the arm, from the swing. Strains are what we do when we over use something. With the Olympics coming up, boy, are they have a lot of strains? I'm sure they are really overusing themselves right now. So here we are. I think probably the most common sprain that I got was playing volleyball. Go up, spike a ball at the net, come down, land on the side of my ankle, and you'd hear, and I'd fall on the floor. I knew immediately, and you could feel the swelling occur almost instantly. So, immediately, what should you do if you sprain? And it's exactly what I did. I immediately sat on the floor because I'm already there, but I put my leg up straight in the air. So now I have elevated it. Okay. I know my coach is coming with an ice bag. She's going to get me to the side, wrap it with an ace bandage, and keep it elevated. So you need to remember the acronym RICE: rest, ice, compress, and elevate. Now, years ago, we would only put on a ace bandage and maybe give you crutches so you couldn't walk on it and give it some rest. Today, because a sprain does really affect the mobility of those joints, especially ankles and elbows and whatnot, they are putting splint things on now. And it does hold it stable and it does help it with the healing. So that's the first thing, rice. All right, then you get to the hospital and you've fallen off the monkey bars and your arms go down and now you've fractured your wrists. Wrists are the most common of all fractures in children because why? You put your hands out when you fall, and those are the bones right there that fracture. Whether one or both, whether one break, multiple breaks, it all depends. So, one of the things you need to remember is infants are very soft and flexible, and they're extremely hard to break a bone. So if we see an infant with any broken bone, it needs to be investigated. I'll tell you a story about an infant. I had a 3-month-old baby come in. It was, oh my goodness, what a busy, busy ER that day. And the clerk came over and said, I have this mother crying. She has a little baby and she really wants to be seen and I feel bad for her. I said, okay, bring her in, no problem. If you think it's concerned, I'll take care of it. Brought the child in with the mother, and it's in the mother's arms. I picked the baby up. I put my hand underneath the neck and the head and underneath the buttocks to weigh it because you need a weight. It's the first thing we do. When I put my hand underneath the scalp, I felt the scalp give away like it was broken. I also noticed a yellow, purple, greenish sort of coloration behind the right ear, and my heart sunk. So I did the rest of my assessment, and now I know this is abuse. I know it's abuse. There's no other reason for this child to have a fractured head. And as a mother and a grandmother and as a woman, I was upset that this baby had a fractured skull. But I'm a registered nurse and I must maintain myself professional. And my job is to get that child safe, right? My job in child abuse is to protect the child. So I did all that, put the child and the mother in a waiting room where I could see them. They were in the little baby room, which was great. I told the charge nurse, I told the doctor who was in charge that day, and he said, do me a favor, take that baby over yourself and do an x-ray of the head. If you see something, do an x-ray of the body. We call them bodygrams because babies fit on a whole chest x-ray film from an adult. We call them bodygrams. Do you know what we found? found a fractured skull. We found a fractured right humerus, fractured ribs, and a fractured femur on a 3-month-old baby. So, what did we do? Well, with that, we know there's abuse. So, of course, we called up Child Protective Services. We had to call the police and all of these things. The end of the story is there was twins. We called the other twin in to check him out, and he had the same injuries. They also had a 2-year-old. We called him in to check him out. So this happened like 5 in the afternoon, and I worked day shift then. I came in the next morning at 7, and they were still finishing the check of all these children. The little 2-year-old boy had a fractured femur, and he was walking on it. So what's going on with those kids today? The person who did this is no longer in their life, and these children are now safe. And that's the bottom line. The mother had nothing to do with it. This is the story. She had these twins. The babies were 3 months old, and the husband got laid off and couldn't work. So she was working 3, 4 jobs, whatever, to keep the house going, and he had to take care of the family, the babies, and he lost it. And he basically took the babies, and they were crying when he was bathing them. And he took them and hit their heads in the shower around all of the tile. That's a horrible story, but that's child abuse. So if you're ever in doubt, always report. It's better to be safe than sorry. That's 3 kids that I managed to get on the radar so somebody could help them. So what are the types of fractures that we can have? The most common is the one they fall down, put their hands out, and they got a break, and there's no break through the skin, and all you see is pain, the child complaining of pain, and there's some swelling going on there. We put on a cast, make sure that bones are approximated, and yeah. Open and compound fractures is when you fall and either a toe, a finger, an arm, a leg, any bone is sticking out through the skin. Now, whenever something comes out into the environment, it is now going to get infected if we're not treating it correctly, right? So, what do you think our priority on this child's going to be? Antibiotics. We want to protect that bone from getting osteomyelitis. And if we are putting this child in the hospital and monitoring it, we'll be monitoring the temperature, because a low-grade temperature is telling us there's an infection, and the infection could be osteomyelitis, and maybe we need a different antibiotic, something to be monitoring it with. A complicated type of fracture is one that bone fragments damage other organs. I think probably the one that explains that the best is a rib fracture, and the fracture then goes through the lung. Very common. That happens. And then there's comminuted, when bones shatter, and there's pieces of that little sharp bone sticking into nerves and muscles, and it hurts. And then this is the different one. You're like, is it a fracture? Well, they consider it a fracture. It's called an avulsion. The bone just rips away from the tendon and ligament, so then it can't be articulated by it. That's called an avulsion. Now, children. What's the difference between children and adults and fractures? Well, children are still growing. And children grow in the bones by something called an epiphyseal plate or a growth plate. And you can see by what they look like, it's at the head of the bone, it gets bigger. That makes you grow from here, okay? So if we fracture any area of that, and if we don't approximate it and line it up perfectly, you're going to have a crooked leg, crooked finger, crooked arm, or a shorter arm, leg, finger, toe, whatever, right? Because when we have a growth plate or epiphyseal plate fracture, they must go to surgery for an open reduction internal fixation. They put plates and screws, approximate, get it exactly where it needs to be so that this will heal and the child grows. Now, this is an interesting concept, and you need to remember this one. Neonates are the first 28 days of life, right? A baby, if they have a fracture, just think about they come out with fractured clavicles a lot during vaginal delivery, right? It's going to heal within 2 to 3 weeks, as long as we splint them. This is interesting when we get to club feet because 2 to 3 weeks is healed. So we got to do treatment quick or it's going to be healed in the wrong position. Okay. Now, older kids cast usually 4 to 6 weeks. Adolescents, you're going up to 12 weeks or so. Me, it's going to be 6 months by the time, I'm healed. But again, you can see as you get older, the healing of the bones takes longer and longer and longer. So children, we need to catch them quick. We need to make sure their bones are in the right position so they heal and won't have, shorter, crooked legs or arms or whatever. So you get the kid comes in telling you, I fell off the monkey bars and my wrist hurts. And you get the x-ray and there it is, that top right. It's a fractured of your bone, right? Your radial bone. No, that's the ulnar bone. And what happens? Well, it's pretty well approximated there, but we need to keep it so it won't move. So we're going to do an x-ray. We're going to see what it looks like. Of course, in any broken bone, we want to do that suspicion of tell me your story. Does it match your injury? Okay, it does. All right, we can rule out child abuse. Another thing we could do with kids just by looking at them is any kid who won't walk on a leg, on a foot, it's going to be broken. If it's just sprained, the kid will try to tap his foot down. But if it's broken, they absolutely will not. So our goal with any fracture, well, we want to get it reduced. We want to get it, completely immobilized the way it's straight and so that the function will be good and there's no deformities. Now, putting a cast on a child isn't the end of the story. When you put a cast on them, remember the cast. When we put it on, first of all, it gets hot. I don't know why, but it gets hot. I guess the plaster Paris or the poly, whatever the type of material it is, it heats. So when it heats, it causes swelling. And swelling can cause compartmental syndrome. So this is why when we send children home, we're going to teach the child and we're going to teach the parent about the things about a cast that are concerning and that they need to report. So if the pain and the point of tenderness is becoming more and more, we know it shouldn't be that way. It should be less now. If it's this color, it's now capillary refill. It's now pale, no pinkness, problem. There's no pulse, big problem. Paresthesia, now I can't move it, right? Numbness, and now can't move it. And I feel swelling and pressure going on in there. If they see any of these things, this child needs to go get that cast removed and replaced or a window placed or something. It needs medical evaluation. Now, I put the extreme case here. Yes, you can get a necrotic arm. All right, that's the extreme case, but it's usually more like the one on the left, where you just see it just starting, something happening there. But again, we can prevent that arm from getting that necrotic. So casting for fractures in children is actually pretty fun. We have all sorts of colors, yellow and two types of pink and green and a couple types of blue. And we have army and rainbow and all sorts of things. And the children, the one thing that distracts them from, I need a cast because I broke my arm and I'm going to have to get it manipulated, is, oh, okay, I can have my team colors on for my football team and I can have it on my cast. And now they think they're cool. All right. And we will do crazy things. Do you see this doll that this little girl has? That's stuff that we'll do that will make her feel like the doll is just like her. And it's actually sort of pretty cool that the doll is her. So again, a distraction. Now you've had your discussion questions talking about fractures. Remember, with fractures, it's all about taking care of that cast at home. I think the biggest complaint is that it itches in there. So again, nothing inside, no lotions, no powders, no hangers, pencils, nothing, because it can rip the skin and create a lot more problem than that. The other thing that we teach them is how to bathe, and we'll give them baggies, a short leg, a short arm, a long arm, small size, large size. We have all different sorts of bags that we'll give to this child and tell the kid, remember, there's garbage bags. We can put those on there too, whatever works, because they have to keep it dry. Now, I'll still never forget this little kid. He was like 6, 7. He had fractured arm, came in, and it was a busy day, I remember. And finally got his cast on, sent him home. Right before I was going home, I see the mother and the kid coming back in. And I said, Mom, what's the matter? He goes, he went home, got on his bathing suit, and he jumped in the pool. So we have to change his cast. I'm like, okay. Well, actually, I found out this kid did it one more time. So 2 times he jumped in the pool after getting the cast on, knowing the second time he'd have to go get another cast. Now, we talked a little bit about that traction, right? Most of all today, we're using skin traction. Skeletal traction is we put a metal pin through a bone and we pull it or displace it, or there's these external fixation things. But let's just talk about regular traction. Now, the bottom picture is Buck's traction. If you notice, the heel is off the bed. We're not touching the end of the bed. There is a rope that has a pulley and weights that hang. Those weights that hang, you can't touch. Your job is to document how many pounds are on those weights when you go in for your shift. What that weight does is, and most of the time we use it for fractured femurs. When a femur fractures, it breaks, and those quadriceps are so strong, it pulls the bones in many different ways. Crooked, okay? And the ends of those bones are sharp, irritating, and painful. So we pull them out, we straighten it up, we decrease muscle spasms, we decrease pain, and we buy time until we can get that child to surgery. Today, they actually put a metal rod down the femur, and that's how they cure it. They don't wait for it to heal like they used to. So the purpose, relieve that fatigue on the muscles, approximate the edges, immobilize it, preventing deformities, okay, which is absolutely your big thing. And the other thing is muscle spasms. Those are pretty bad. Now, these 2 pictures are actually skeletal traction. If you notice, they're metal things. Now, the top left one is tongs. We use this for cervical breaks, okay? We've used that quite successfully. And then the other one is a halo. Sometimes children have this issue with their top 2 vertebrae, the atlas and the axis, and there's things that can go on. It's called a Chiari malformation, believe it or not. And it has to do with the way blood flows and cerebral spinal flows up into the brain, and it gets kinked every now and then. So this child passes out. So they find out this, and they do the surgery, they fuse it, and they put this on to immobilize again. Again, doesn't matter, it's an immobilization. So let's look at the couple skin tractions here. Bucks, as we know, is skin, it pulls it, used for femurs. Again, there's a weight. Make sure that it hangs freely and you never take it off. Because you take it off, those bones are going to separate and you're going to create pain. So you don't want it. Leave the kid bed rest, leave that weight on. Now, Russell's traction is just like Buck's, but there's an extra piece there. Sometimes they use it, sometimes they don't. Actually, most of the time I see them not use it, okay? But it is available. And then the bottom right. Now, you saw the little picture in the beginning on that Pavlik harness on that little infant, right? That little infant, we try to get those hips in, but sometimes they're about older and it's not working. We can put them in something called Bryant traction. It is, if you see the baby's position, this is the important thing. It's a right angle. Buttocks are slightly off the bed. So now you're really pulling those hips to get back into where they need to go. Okay. But this kid cannot weigh more than 30 pounds. Okay. That is Bryant traction. The other things that we have in skeletal traction, as I've mentioned it, is that external fixation device. It looks like Frankenstein, doesn't it? Why do you think we would use something like this for? Believe it or not, there are kids who are born with shorter legs, shorter arms, and one leg shorter than the other, or, sometimes they get such a horrible break that a cast won't work and they need to just get that as positioned as they can and fix it with this external fixation device. So there's a bunch of pins going into bones in many different places here. So what do you think your treatment here is going to be? Well, checking neuromuscular signs, pin care, checking for infections. That's the big thing there. And they actually will tell you to, sometimes there's screws, they'll tell the parent, the child or the parent, go home once a day or every other day, take and screw that one screw around, this screw, this screwdriver, screw it one time around. Sometimes they do those sort of things. So that's an external fixation. And then babies can be born without limbs. I've seen babies born without lower arms. I've seen them born without lower legs. I've seen them without fingers, without toes. All different things can be at birth. Now, I actually had a friend who had a daughter who was born without an ulnar bone. No, wait, the tibia and the fibula bone in her leg. It wasn't there at birth. So she had one of the bones, but she didn't have both because you need the two bones in the lower legs to be able to stand up. So you can't just put a bone in there. So they had to do a below the knee amputation. And I met this girl when she was about 4 years old. And she came into my house, and my kids, they don't care. Kids with disabilities, I mean, that's not a big deal at all. We play with all kids are the same. And this little girl took off her little prosthesis, and she was chasing my kids all around the house, up and down the stairs, having so much fun, giggling and laughing. And the kids had fun with it because she didn't know any better. Okay. So that's a kid with an amputation. Now, after an amputation, whether you're an adult or whether you're a child, know that there is going to be those phantom pains. There's going to be all of those things that we need to check, like the making sure that the stump is clean and it's not infected and it's healing properly and there's no abrasions from your prosthesis, et cetera, et cetera. So again, and treating that phantom pain, we know it's part of it. Now, kids in sports, they love to do sports and they love to win. Remember, sports, there are all different types, and kids can get really, really rough. So there's rough contact, there's big physical commands on it. And do they always have the proper equipment? Or are they out playing with the neighborhood kids? And now, they have a chance to get hurt. And of course, we have those overload injuries. Here we are with those overuse injuries. This is like your strain, right? This is when you keep doing the repeated movements and the same muscle groups over and over and over again. And it does cause this little micro traumas, et cetera, called overuse syndromes. Okay, here's that hip dysplasia, that Pavlik harness, that's that Bryant traction. So babies that are born, usually their hip socket and hip are just perfect. That's why the pediatrician on the first visit takes the knees, puts them up, pulls them out, and he listens for any clicking going on. Also looking at the gluteal folds, making sure that they're equal. Also, one leg is going to be shorter than the other if it's dislocated. Because if the bone should be here and now it's up here, you can see that leg is going to be shorter on the side that's affected. More girls than boys are with hip dysplasia. So this is what we are going to be looking at. We're going to look at those hip joints. We're going to be looking at that shortened limb. We're going to look at that, looking at those gluteal folds, making sure that they're equal. And then positive Ortolani, positive Barlow test. It means the hips click when they're going in and out of joint. Click, 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 and you can hear it. So remember what I told you about bones and healings and newborns, because this is found as a newborn, okay? They heal within 3 weeks, don't they? So the quickest that we can get this child into that orthopedic, whatever they need, the quicker they have the opportunity of getting that hip back into joint, right? So early intervention, as quick as we can figure it out. So they say that how do we treat this hip dysplasia? Well, for the first 6 months, we'll put that Pavlik harness on. What we are attempting to do, and this is an important word, they try to abduct that hip to get it back into where it needs to go. So it's an abduction of the hip. After that, sometimes we'll put spica casts on, sometimes we'll do the Bryant traction. And if that doesn't work, now all these tendons and ligaments are tight and they're not going to move. So in order to get that hip back in, if it's still not at 2 years old, they're going to have to do surgery. And they basically cut tendons and they basically, make those tendons and ligaments and stretch them to get that back where it needs to go. But it's very difficult to do that because of all the scar tissue, and how long it's been there in that position. Now, I've also mentioned quickly club feet, and I've also mentioned about that quick bone healing, right? So you don't need to know all the different names of club feet. All you need to know is they could go in, out, up, down, anywhere these feet could be in the wrong position. So we need to get them in a position where this child can stand up and walk. That's our whole big thing with this. So how do we correct it? You don't need surgery. These children need something called a Ponseti method, and it's casts. And we put one cast on every week. Remember, I told you they heal in 3 weeks. So as they're healing, we need to every week get a new cast so we get that ankle exactly where we want it to be by the end. And I showed you all the different casts, 1, 2, 3, 4, 5, 6. So this child had 6 weeks that they had casts on them. The interesting things about children and getting these Ponseti casts on, on their lower legs. I actually saw a mother come in with one in her hand. A newborn got out of it one night. I'm like, how did they get out of a cast? Have you ever seen that? I never had. I'm like, okay, this is a new one on me. And of course, we went to orthopedics. They put a new one on. But it was interesting how a newborn, talking 2, 3 weeks old, could get out of a cast. I don't know how it happened. But again, this is a child that you have to monitor their feet as they get older and start to walk. They're going to need follow-up with orthopedic or podiatrist to make sure their feet are laid correctly. They might need some special shoes as they start walking to maintain the integrity of those feet. Now, this is an interesting diagnosis. It's called osteogenesis imperfecta. It's another name for brittle bone disease. In my career, I've seen one baby that I took care of, but I've seen many a child in their wheelchairs going beep, beep, beep as they're going down the hallway to the cafeteria. And they're osteogenesis imperfecta because you can see all the bone disfiguring on them, but they're alert. They're alert children. The problem, these are children that are born that look okay, but with minimal sort of touch, you can break a bone. Now, as a nurse, this is an interesting child to take care of. You have to lift them up, you have to change the diaper, you have to put thermometers underneath their arms. They need to be fed. How do you touch these children without putting your arm and cracking a rib or lifting an arm up and dislocating a shoulder? I mean, I'm telling you, these bones do break easily. I used to use a baby blanket to lift them up and move them around a lot so I didn't have to touch the child, and I'd always have somebody help me. So, how do we treat? Well, there's no cure for it. It's just something that they have to live with, and mostly it's supportive. Now, there are some things we might give IV biphosphonate therapy, but there really is nothing that will prevent it from keep going. I mean, they're still going to be breaking bones. They still have brittle bones. Our goal as healthcare professionals is to make sure that this child maintains some sort of positioning that they can be mobile, whether it's they can able sit in a wheelchair or sit in something that they can move themselves, because you're going to have all sorts of contractures, deformities, and weakness and all of that. But we try to keep some sort of alignment if we can, in order to give that child some outcome as they get older and can be more mobile with these electric wheelchairs. Now, late calf birth. I think I had this as a young child. Actually, I was just out of nursing school. I was 20 years old, and I'm sure this is what it was. Late calf birth disease. This started as this pain in my hip, especially when I got up, but it went on for quite a while. And I went to orthopedics, and basically he said, there's no infection, there's nothing. You just need to take NSAIDs and just keep moving, and it's going to be okay. I'm like, okay, but it depends on the severity of the child. Now, our biggest concern, late calf birth, is the femoral head all of a sudden doesn't get blood. So it's ischemic. So it's going to get necrotic, right? But it's not due to an infection, aseptic. So it is lack of blood flow without an infection where the tissue dies. That's what it means, okay? So a young child, what are we going to do? Well, this again is like what I felt. All of a sudden, you started limping, soreness, stiffness. It was that limited range of motion and limping, especially in the morning when I woke up, or if I sat down for a while and tried to get up. X-rays were done, and they saw that little fuzzy on my femoral head. So I'm sure this is what it is. So what do we do? Well, we want to try to make sure we keep that head of the femur, where it needs to be, and we need to try to make sure that we get blood flow as we can. They say in the severe cases of these, they need to be on bed rest, no weight bearing. NSAIDs, right? These are the non-steroidal anti-inflammatory. Sometimes they've got to remove it, but that's those rare cases. And this is another one where we could put Buck's traction on at home. It sort of pulls it, relieves the pressure, and gives it every opportunity for blood to be able to get in and to that femoral head. Now I'm going to go into 3 different spinal conditions. One is called lordosis. Now, lordosis is when your lower back, the cervical back there, sort of humps back. I call it a humpback, and you're going to see that, the humpback there. You see it a lot more in older people. Let's see, hold on. Kyphosis is the one. This is your humpback. I'm sorry. Kyphosis is your humpback. It's your upper spine. Lordosis is the lumbar spine. Now, the interesting thing about lordosis, this is one of our neuromuscular diagnoses we're going to go into, that they are apt to get lordosis. It's one of the things that we do see in it. And then most tested of all of the spines is scoliosis. Scoliosis is an S-shaped curvature of the spine, usually occurs right at that pre-adolescent growth spurt. And that's when it becomes more obvious, okay? What all of a sudden they start to see is the shoulder dropping, leaning forward. All of a sudden the clothes don't feel right. I know that years ago they did school screening. I don't know why it's controversial now, but it's what the book says. So you have a child with this curvature of the spine. The problem with the curvature is that curve goes into where the lungs sit. So it goes into the chest cavity and pushes a lung over. So if it's a real big curve, you're messing with my respiratory system, okay? So we need to straighten that out. So there's two different options for treatment. If the curvature, let's put it less than 45 degrees, this child can get one of these little braces and they can do all different sort of colors, sort of wonderful things, but to put a cotton t-shirt underneath because they're plastic, they sweat. No lotion, no powder, and it must be worn 23 hours a day. They can only take it off to take a bath and to check the area for any abrasions, rub those areas if they need to. No lotion, no powder, put the brace back on. They also will do physical therapy and strengthen up the core muscles in the abdomen and in the back. And that's the treatment for less than 45 degrees. Now, what happens if we are that bigger, 45, 50-degree curvature of the spine? You're really impeding upon my lungs. They're going to do something called a Harrington rod. The Harrington rod, they take the spinal cord and they take a bar or a metal rod on either side of the spinal cord and attach it to the little pieces of the spine. And it straightens out, not completely, but it does give the lungs more room to breathe. Now, post-operatively, these children are flat in bed. This is your log rolling patient. You know, we've heard about log rolling, right? Well, this is a patient. Because if you don't, you're going to twist that rods and you could break off a piece of spine. You don't want to do that until those rods are really adhered. Now, osteomyelitis. What is osteomyelitis? Well, this is an infection of a bone. What would you see? Well, usually you start with like some sort of tenderness, redness, pain in somewhere. Could be in a finger, a toe, it could be anywhere where the skin's open and bacteria's gone in and now it is attacking your bone. Okay. So this child, if it's true and real, they're going to have the redness, the swelling. You're going to see they're going to start with fevers, but they're also chills because they've got this the sepsis going on. It's getting worse, you know. So you see the fever, you see the chills. Marked leukocytosis or elevated white count in the CBC. So many times, if we can, we'll do some sort of culture. If there's nothing open, we're not going to reopen it to stick something in there, okay? Usually. So we can do a culture. Yeah, we'll do that for the antibiotic. And absolutely, we'll do x-rays or bone scans. We want to make sure how deep is that infection. But this is a child that's going to be on long-term antibiotics. Do you remember about aminoglycosides, the CIN drugs? They're used for staph. Now, usually when you open your skin to the environment, you're always concerned is staph. That's always the bacteria that we're concerned about. The antibiotics that treat this are vancomycin, gentamicin, amikacin, the CIN drugs. Remember, those are aminoglycosides, and they're extremely toxic if we do not work with them very closely. Remember, these are children that are going to need peak and trough levels to make sure they have enough of the drug and that by the time we give the next dose, that there's not too much there, that we can give another dose. So we'll do peak. We'll do troughs. We'll be monitoring their hematologic or CBC levels. Is the white count coming down? We'll be monitoring their kidneys, their renal. We'll be monitoring the BUN, their creatinine. We'll be monitoring urine output. We're also going to be monitoring their liver, making sure their liver enzymes okay. And the other thing, we're going to be checking their hearing, right? Aminoglucosides or drugs with CIN, their biggest side effects are ototoxicity or hearing loss and nephrotoxicity or kidney damage. Okay. So these children with osteo, usually depending, they'll be on bed rest. They'll need those long-term antibiotics, usually with a PICC line for osteomyelitis. And now we've got a child at home on bed rest. Again, how do you aid healing? Well, we aid healing by nutrition. And how do we give nutrition to aid healing? High in protein. Does that make sense to you? Protein, protein. And again, remember these kids need, somebody to help them through this time at home alone. Now, I threw Ewing sarcoma in here because it is a bone tumor and any bone can have it. Sometimes we can take bones out, sometimes we can't. We will do radiation, chemo, and surgical if we can. Sometimes we can't. And of course, any cancer, we always are concerned about metastasis. Now, juvenile idiopathic arthritis, very hard to very difficult and very hard in order to diagnose. These children are usually young, those toddlers, and all of a sudden you'll see them limping or they're complaining of something. Sometimes you think they fell down or they're on they were outside playing in the yard yesterday and they just, oh, it's nothing. Well, and then it continues. And these symptoms are evolving. So in the morning, you haven't moved your joints all night long if you've been sleeping, right? So you have stiffness, joint stiffness. I know I have JRA. You know that. I've told that to you before. In the morning when I get up, I have to sit there on the side of the bed, stretch out the hips, and then you need to stand up, and I need to stand there for a second. I need to wiggle, and then I can start to walk. That's part, or I'll be like waddling, trying to get to wherever I need to go. Also, there's limping. If there's pain, you're going to limp. JIA is all about the body attacking the joints. So there's joint swelling and joint disfigurement. And the one symptom that students forget about and always don't check off on exams is uveitis. Their eyesight can be affected by rheumatoid juvenile idiopathic arthritis. They need to have eye exams in order to check it. Their eyes turn red. It looks like this when it gets uveitis. So how do you diagnose rheumatoid arthritis? It's very difficult. It took me almost 10 years to be diagnosed with rheumatoid arthritis. They kept telling me I was fibromyalgia. In children, the same thing, their aches, their pains, they're growing, they'll grow out of it. These are things that you hear. And those aches and pains don't go away and they get worse and worse. So what sort of labs could we draw to try to figure out what's happening? Well, rheumatoid arthritis or idiopathic arthritis is an inflammatory condition. So let's look at the inflammatory factors. So let's look at the SED rate. It could be elevated, it may not. There's another one called CRP, C-reactive protein. Sometimes that's elevated, sometimes not. Sometimes you have elevated white count, sometimes you don't. Sometimes you have a positive rheumatoid factor. Sometimes it's negative. Sometimes you have a positive ANA. Sometimes it's negative. And this is why it's so difficult to diagnose this idiopathic arthritis. They actually came out with a new test, which is the one, oh, how many years ago now? About 7 years ago, 6 years ago. They finally came out with a test. It was a newer one, a send out, of course. It's a CCCP. So my doctor said, "Oh, let's check it. Let's see it is." I don't think so, but why not try? I said, "Okay, I'm game for that." So he calls me up about a week later and he says, "Betty, you have your CCP level back. The normal is up to 50. Your number was greater than 250. He says, "You have rheumatoid arthritis." I said, "I've been telling you this for a year now. You're not listening." So finally got on the proper treatment for rheumatoid arthritis. And of course, they start you off with steroids. Let's get rid of that pain first. And then what do? Well, the goal in idiopathic rheumatoid, whatever arthritis you want to call it, is to keep the joints moving. What is the cure? Well, it's different for everybody. I think I've been on 6 or 8, I'm not even sure anymore, different types of infusions, pills, injections that didn't work, didn't work, didn't work. So you got to keep finding it until you find that one. Because if you don't have something that tells your immune system to chill out and relax, the pain goes on, the joint damage continues, so it hurts. So once we get those symptoms under control, then this patient, even me, can get up, get out, can move, can walk. I love a swimming pool. I think it's the best place for me, but everybody has their own thing for it. What is the drug of choice for pain? We want an anti-inflammatory, don't we? NSAIDs are the drug of choice for pain for juvenile idiopathic arthritis. Okay. And as I said, corticosteroids to help with those flares. Those are like the band aid to help you right now, but it's not long term treatment. And then also, they put you on methotrexate. Initially, I was on some oral pills, but now they have me on a sub-Q once a week. And the combination actually does help me. So physical therapy is my get up, get walking, that's chasing my grandkids around, and that's going into the pool, right? It's keeping me without pain, using, whatever medicines I need to help me, or just the movement helps me most of all. And again, in pain, there's two different methods to go. You can either like heat or you can like cold. Now, most people love heat. Do not put heat on me. It makes me worse and I'll start to cry. Give me an ice bag, an ice bath, and just drown me in it. That's the only thing that helps me when I hurt. So again, ask the child. Now, lupus is the other side of rheumatoid arthritis. This is the body's attacking all the organs. It's a lot of girls, and it is triggered by hormones. So maybe that puberty sort of thing, immune disorders, infections, stress can cause it, and sunlight. Overexposure to sunlight can cause lupus. I live in South Florida. So what do you see with lupus? Well, it calls it a cutaneous lesions or lymphadenopathy. This is a butterfly rash. They can look like anything. It doesn't have to look like that. It's just some sort of redness on the cheeks. It could look a little spotted or it could be darker. They're all different colors, all right? What they complain of and usually starts to bring them in for treatment is nausea, vomiting, diarrhea, and pain. It doesn't stop. And then it starts with the weakness and the stiff stuff. But then all of a sudden, a forgetfulness, maybe a seizure, maybe some paralysis. Again, that's when they come in for treatment. Up to that point, they don't know what's going on. But finally, when they see the rest of it, they can rule it out. Remember, if it's lupus, this is proteinuria and renal failure. Remember, lupus can attack the kidneys. The kidneys will start dumping protein because it's hurt, it's damaged, and it does cause failure. So therapeutic management, well, whatever pharmacology the doctor wants. A lot of times they'll put them on a low dose steroid to help them. There's other medicines they use, there's all different things. But the biggest thing about lupus is to remember keep them out of the sun or minimal, or use sunblock, or later in the day or earlier in the morning. So here's a question. Kristen is 10 years of age and sustained a fracture in the epiphyseal plate in her right fibula when she fell out of the tree. When discussing this injury with her patients, the parents, the nurse should consider what? What's an epiphyseal plate fracture? Anybody? What's an epiphyseal plate fracture? Is that a big deal? Nobody knows? You can guess. What's an epiphyseal plate fracture? What's our concern? Remember, broken bones in children are different than adults because children are still growing. An epiphyseal plate is where the bone still grows. So, if we have a fracture, we are concerned if it's in the epiphyseal plate because your bone growth will be affected. You'll have a crooked bone, a short bone, and you don't want that. Remember, these need open reduction internal fixation. Okay, let's go to our Kahoot. Who would like to win a Kahoot today? Nobody? You guys aren't lively for me today. Is it Friday? Is that what it is? Remember, I don't look at who does what on these. What I'd like you to do is try to play it, try to make the answers. And if you don't know it, write down that concept, something that you need to look up. It helps with your studying. Okay, we'll get going. Muscular skeletal. Multi. What is a priority for a nurse to assess following a cast application? Remember 6 P's. That's what you're going to teach the parents, and you're going to teach that to the child too. What do those P's mean? Pulses, pain, movement, sensation. Movement is paralysis, sensations, paresthesia. Yes, all of the above. P, 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 P. A multi. Parent teaching for a child with a fractured bone that has had a new cast applied. So the thing with new cast is nothing inside of it. No powder, no lotion. They think that's going to help with it, but it just collects there and it becomes like a petri dish for bacteria and fungus and mold and all sorts of things. So none of that in there. Don't stick anything in there. You could rip the skin and create a really bad infection. They say that cool hair dryer actually works. I've actually recommended that over and over again to the kids. Put it on high setting and just put it in there, and that does seem to help. They have things like their other blowers, like the leaf blowers in the house. I had one kid tell me he had the father do that to his arm. I'm like, be careful you don't put stuff in there. He said it helped. What should the nurse monitor after a soft tissue injury? Remember, these can be very deceiving. Looks like a little bruise on the outside, little ecchymotic area, but we don't always know. So, big thing about bruising or injuries, always check distally to make sure the blood flow is still going there. Just because it doesn't look so bad on the outside, you don't know what's going and what's compressing on the inside. A fracture that penetrates the skin is called. So, a fracture that penetrates the skin is called an open or a compound fracture. And remember, once that skin's open, we're worried about infection and prevention of osteomyelitis. So, multi. Bryant's traction. That's what we use after a Pavlik harness or the spica cast is not working. We're going to try a Bryant's traction. There's certain things you need to know about using it. So it has to be kids less than 30 pounds. It is skin traction because it just pulls by skin the legs up. The hips are at a right angle and the buttocks are a little bit off the bed. That's the big thing there. And always, any traction, the rubbing thing, always check for skin breakdown for sure. What is a priority nursing care of a child with a compound fracture? Priority. What's their biggest concern? Co Compound or open fracture. It's all about antibiotics, okay? Because we're worried about this child getting osteomyelitis. Yes, we are going to do neurovascular checks. And I knew this was going to come out 50-50. But your priority is to prevent that infection because it doesn't matter if blood flowing or not. If there's an infection there, the child's going to go septic. What is priority nursing care for a child who fell off a second floor balcony? You know, I've seen three kids, toddlers and a small preschooler, climb up on a chair and go over the second floor, onto the ground. Three of them. So, whenever you have a fall, you have something that you're concerned about the spine at all, your priority is to immobilize it immediately because you can get this kid, they fell off the second floor, that they're awake, they're alert, there's no problems. You don't immobilize them, you bring them to the hospital, you twist their neck, and now they're paralyzed from their neck down. So, you make sure, number one, rule out the break before, you put the thing on, rule it out. Don't not protect that neck. Principles of managing soft tissue injury include I jumped up, spiked that ball, came down on my ankle, and oh boy, does it hurt. What do I do? It's rice. Rest, ice, compress, and elevate. That's exactly what we do. And actually, we should be teaching children and even sports people. If you're out playing sports or you're falling down, this is what you should do. It helps. An epiphyseal plate fracture in children may what? So epiphyseal plate, it's all about the growth plate, and we're all about making sure the bones are straight and the lengths are the same. We don't want to disrupt the growth. Very good. What findings for a patient in skeletal traction indicate peripheral neurovascular impairment? What does that mean? Neurovascular impairment. So, neurovascular impairment means you've got somebody in traction. Remember, we always check the neurovascular signs distally. So, if we have an impairment, which means the flow's not as good as it should, an absent pulse is an absolute emergency because we need blood flow because the toes and stuff could start dying. And what do? Call the doctor immediately. Call the doctor immediately. A multi. How should the nurse care for the skeletal traction for a child with a fractured femur? During Buck's traction, what do? So, Buck's traction, any traction, number one, document that weight of the traction every shift and never, never, never remove it. This child is on bed rest only. And the other thing is you need to document weights hanging freely, no obstructions with this amount of pounds of weight. That's what should be documented. Very good. When caring for a 9-year-old in Buck's traction, what action by the nurse is correct? So we're going to check the neurovascular signs, capillary refills. Absolutely, that's our priority, making sure blood is flowing. Absolutely. What position do you put the legs of an infant with hip dysplasia? It is called abduction. Okay, that gets that hip back into place. What statement by parents indicates more teaching regarding their 2-month-old infant with club feet or a 2-week-old? Yeah, 2-week-old infant with club feet. What do we know about club feet and what do we know about new babies? So we need to be changing those casts every week. We need to start it as soon as we can. And you know that follow up with orthopedics or podiatrists absolutely is going to be needing. Now, You would not wait 1 month for a new cast because remember, they heal in 2 to 3 weeks. So now you've healed them in the wrong position. So you want to keep changing it till you get it to where you want that foot and that club foot to be. Very good. Multi. Osteogenesis imperfecta. I saw a documentary on some parents that had children with osteogenesis imperfecta and they didn't diagnose them and they were tried to be charged with child abuse because they kid had broken bones. It's a reality that can happen to these children. I actually seen two documentaries like that. I watch that weird stuff because I'm very interested. So OI is brittle bone disease, and everything gets crooked. And our goal is to try to maintain some sort of form that that kid can maintain some sort of mobility. Aggressive physical therapy would break every bone in their body. We don't do physical therapy on these children, okay? Because it's absolutely that opposite of what you would think. You can't because you will break them. What is pathologic cause of leg calf perth disease? So leg calf perth is where the blood stops flowing and it's not infected and the femoral head dies. Ischemic, septic necrosis of the femoral head. Treatment, bed rest, NSAIDs, maybe some Bucks traction, and it just takes time for it to heal. Kyphosis. So kyphosis is also known as humpback. That's the upper spine that goes over. You see that more in the older people when they start, leaning over. A multi. Which assessment indicates an infant has developmental dysplasia of the hip? DDH. So DDH in infants, we're going to have those asymmetrical leg folds or gluteal folds. We're going to have those positive Ortolani signs. Everybody has Babinski, okay? That's the bottom of the foot. That has nothing to do with developmental hip dysplasia. You're going to hear those clicks. You're going to see those developmental, those folds are going to be crooked, and you're going to see that leg, which is going to be one shorter than the other. Lordosis is described as. And that's the inward curvature of the lumbar spine. They sort of like sway back, it's sort of called. They walk backwards. Scoliosis is. My daughter's best friend had scoliosis and had to go through those braces and all the physical therapy. And it was amazing being crooked and you watch her straighten right up. It is an S-shaped curvature of the spine. Remember, greater than 45%, they need surgery. Less than that, they can have physical therapy with that brace on, and they have to keep it on 23 hours a day. Adolescents with scoliosis that have up to that 45 curvature of the spine would need to do what? So up to 45, what are we going to do? So up to 45%, that means it's not severely, severely bad. We can do physical therapy and a brace, and we can get that spine more straight so we can get that lung more room to breathe. Remember, 23 hours a day with that brace on, with a white cotton, well, cotton t-shirt underneath. White is preferable. And then they could do their exercise or physical therapy. And that's the way that we do treat it. A multi. Teaching for a child with scoliosis with less than a 40 degrees of curvature. 23 hours a day, cotton shirt underneath, no lotion, no powders again. And again, it's physical therapy. Very good. A multi. Pavlik harness. So Pavlik harness is what we use on the little small babies up to 6 months old, where we try to put those hips into abduction to get that hip joint back into the socket where it needs to go. You need to be checking the skin, making sure there's no abrasions, and then you can massage those areas, to get the skin flowing if you see some redness or stuff going on. Again, 23 hours a day with a cotton t-shirt underneath. What is osteomyelitis? It's an inflammatory condition of the bone caused by infection. Remember, itis is infection, osteo is bone. Goals for juvenile idiopathic arthritis includes So what is JIA? It's the body's attacking the joint. So what would be our goal? Is to reduce the amount of joint pain and swelling. Absolutely. Stop the body from attacking itself. What priority action should a nurse take to a patient with a suspected spinal cord injury? I was the primary nurse on trauma one Saturday, and I get a call. 15-year-old boy slid into third base. His head hit a defender's knee, and the stands heard a crack. When they went to check the child, he already had some numbness down his right leg and the left leg. He's feeling a little bit. Thank goodness somebody at the scene knew not to touch the boy. They called in, a helicopter came, put him on the backboard, strapped him in, and brought him in. And I'm the nurse who's now in charge of him. This is a 15-year-old boy who is strapped down, who is numb in his legs, and is scared to death. So my first job is to tell him who I was, what I was going to do, and what was going to happen. And I stayed with that boy and told him everything that was going on, and he kept calm the whole way through. I actually had to do a MRI in the emergency room, which is never done because it's just too much. Usually just a CT. MRI that's when they go to the floor. But this child had an angulated, it looked like this C-spine at 5'6". It was a big kink. I mean, this child was in very severe distress of going paralyzed, okay? So during this MRI, I took control of his head and neck, And I wouldn't let anybody touch that child unless I said 1, 2, 3, go. And we kept this child good. All right, we got him upstairs. We put him to ICU. We put tongs in his head to hold that cervical spine straight till the morning where he could go to the OR. Now, what was the follow up on this kid? He had the right leg was completely paralyzed, and the left leg had some numbness in it, but he still could move it. I went to his room 2 weeks later. He was going the next day to rehab. His left leg was completely back, full function. The right leg had some slight tingling in it, but they expected full recovery. Let me tell you the end of the story. 1 year later, about this boy came in to see me one weekend just to give me a hug and to tell me that he was doing great, he was perfectly fine, and to thank me for keeping him calm during that visit. So, primary trauma nurse, stressful as heck, right? But boy, I took care of my kid, didn't I? It's all that matters. And last question. Most common causes of spinal cord injuries are we know motor vehicle is always going to be, any injuries is always going to be number one in kids of any ages. And of course, driving sports for sure, and just being normal kids. Number three, Aaron. Good job, Aaron. Number two, Jazz. Good job, Jazz. Number one, drum roll. A. LV and Amaya. Good job, Maya. All right, what we're going to do now is go back to our neuromuscular, do that in our cahoots, and then we're running about perfectly on time right now. Let's go back to our PowerPoint. Any questions? Yeah. Neuromuscular or muscular dysfunction. Many of these are progressive degeneration of muscle function. So let's go into this one. So, cerebral palsy. When you think of muscles and not working right, and you think that sort of thing, you think of cerebral palsy. Cerebral palsy happens for so many reasons, I don't even know what all. A lot of times I've seen it's a hypoxic or an anoxic episode at birth that caused it, but it could be some brain malfunction. It could be anything that could occur. Many children with cerebral palsy also have epilepsy. Now, the cause, the gross abnormalities of vascular obstruction, and as I said, hypoxic, anoxic, premature infants. Why are premature infants more at risk for cerebral palsy? Well, their brains are the vessels are very fragile. Sometimes a loud knock, bumping one of those cribs, sometimes loud noises can create a brain bleed on these little premature infants. And that sometimes, depending on where the bleed happens, can cause cerebral palsy. I've seen them have very bad brain bleeds and not really have cerebral palsy, and I've seen minimal brain bleeds that have quite severe cerebral palsy. So there's no rhyme or reason. So diagnosing cerebral palsy. Well, when these babies are born, especially when we have suspicions, an anoxic, hypoxic episode that we know of, or they're premature or something, they're going to be monitored very closely for signs and symptoms of cerebral palsy. What we will see is hypertonicity, poor posture, and difficulty maintaining balance as they try to get up and move. They can't. Okay. They're going to be cognitively delayed. Absolutely. So, gross motor delay, fine motor delay, abnormal muscle tone, alterations in muscle tone, abnormal postures, This is a child, many times you think of cerebral palsy, you think of spastic cerebral palsy. I know at the facility where I did clinicals, there was a little boy called Jonathan, and he was nonverbal cerebral palsy in a wheelchair. And this kid would see me and knew I was going to go up and hug him and tickle him all over. He just knew I was going to do it every visit I went there. So this kid was spastic. So he would see me across the room and his hands would come up and he'd go into because he knew I was coming, that tenseness, that tightness of the muscles. That's what we mean by those alterations in muscles. Because usually you put your hands out, you don't have to, go that tight and spasm. That's cerebral palsy. So these children, what is our goal? Now, little Jonathan didn't speak. We don't know how much he was there, but we wanted him to be able to get up and to move around. Now, this child, not yet, wasn't old enough yet to have an electric wheelchair of some sort, but he was up in a wheelchair that we could push him around. Other children will give them a walker, put braces on, whatever they need to do to get them walking. This little kid here, he has a little tricycle. It's a form of locomotion and it's actually exercise. He's got his splints on, he's ready to go, and he's excited because he gets to move on his own, go where he wants to go. And nursing is happy because he's getting exercise, because he is doing those motions. The thing with these kids is, I've been working with cerebral palsy and cognitively delayed children since I've been in high school. I used to teach them swimming. I used to go and volunteer at the Cerebral Palsy Center. So I've got really, really close with them. Now, I was young then, teenager. Back then, this is a few years ago now, we didn't do physical therapy, occupational therapy, speech therapy. We didn't teach them. We just did basic care, turning, positioning, feeding, getting him out of bed. Nothing really more. Jonathan, this little 8-year-old nonverbal cerebral palsy child, is in speech therapy and he has a little pad and he was learning colors and shapes and numbers that wasn't done before. So again, provide opportunities adapted to the kid that they can learn. And when he got it right, he would giggle. You would see the smile come up. And when he would get it wrong because he did it wrong on purpose, you would see him, you knew he did it like that. So again, these are things, the cerebral palsy, don't ever think they're not there, because this little Jonathan, he taught me. So, because of all these abnormal muscles and the tenseness and whatnot, ankle foot braces, they do help keep that foot more solid. Any sort of orthopedic surgery that can help. And then pharmacological agents to treat pain related to spasms. Um, they were actually using a Parkinson disease type of medicine with Jonathan. And it was used actually quite well and it helped a little bit. They also, if there's spasms going on, maybe problems with the mouth and chewing, they might even put botulism to stop that spasm so that they have more control on it. Remember, I told you there many of them have epilepsy? What do epileptic patients take? They take those medications, right? Epileptic medications. What are side effects? Remember phenytoin? Remember Dilantin? That's the one that causes gingival hyperplasia. So good dental care, very important. So you're seeing how we're getting CP and now we're getting into medicines and we're putting them all together now. So prognosis, well, it depends on how severe they are. I mean, most of them can get up and move, but there are many that can't. Jonathan was one. He couldn't be moved. So he's going to need care for life. So again, that depends on what the parents got planned for him, isn't it? Now, as he's growing at home, these families need help at home, whether it's equipment, whether it's medications, whatnot, making sure that they get everything they need for home and that they understand what they're doing. I think one of the biggest things is teaching them safety. I know little infants falling off of changing tables. It shouldn't happen if we strap them in right. Same thing that goes on with these children. If they're in places in a wheelchair, they need to be strapped in because they'll slide right out. And of course, getting them all the therapies that they do need. And I know that families are very appreciative when we do things for them. I had a little 18-year-old cerebral palsy girl who every day I went in, I used to paint her nails. And her family, when she aged out of the center, the mother came in to see me to thank me for doing her nails. She really enjoyed that, and it really made her feel special. So she was going to miss me. So I gave her the nail kit that I had bought for that little girl. So she was appreciative. Now, neurotube deficits. Do you remember in pharmacology they taught you about folic acid? And if you take it, you would not get neurotube deficits? Well, this is what a neurotube deficit is. What it is the insides of your spinal column and meninges and nerves are pulled up out of the lower half and up over around the back. And it could be a little bit bulging out, that's the meninges you see, or a big bulgy out coming out. We usually call those myelomeningocele, or sometimes some people call it spina bifida. There's reasons why it happens, but a lot has to do with that folic acid and taking it. Now, what is your job? You get this infant that has the insides on the outside, priority. I want to protect that from infection. So, sterile, normal saline, wet dressing. And the other thing is we need to maintain the integrity of the skin because that's going to go back in and I got to close the skin. And if it's abrased, a scoriated skin, it's not going to go together. The other concern, besides infection, is this child has decreased nerve sensation because we've pulled nerves from the lower extremities. So there's going to be decrease in motor and sensory for sure, but we're going to have to be monitoring urine. Can they urinate by themselves? Or are they going to be a catheter for life? Also monitoring their bowels, making sure they're not constipated. As I said, taking neurotubes is what helps. Spinal muscular dystrophy, type 1, probably the saddest of all of them. This is called a floppy infant. This is a child who will never lift their head up. This is a child who doesn't suck, swallow, and breathe. And progressively, they get worse till the age of 2, and they usually die. So this is a very sad child. It's called Werding-Hoffmann. Now, the most tested of all of your diseases, your neuromuscular, is Duchenne muscular dystrophy. Duchenne muscular dystrophy is a condition that mommy passes on to the baby, to the boy, only a boy. These are boys, not girls, that get this. And what do we see? Well, usually they're a little cognitively delayed, they're a little bit overweight usually because they don't move as well, but you're going to see their calf muscles are going to be hypertrophic. And then all of a sudden, you're going to see these children falling down. They have been walking and now they're falling down more than usual. Okay? Now, this usually we were walking and now we're seeing the progression backwards. That usually happens about age 3. So now we got to figure out, why is this kid getting weaker and weaker and weaker? Well, we see those hypertrophic calf muscles. We see that in most of them. We see them progressively getting weaker. So we need to do something called an electromyography. Now, an EMG is that little machine there, and all it does, it delivers an electrical shock. And the machine measures how quick the muscle responds to it. So when this child is done with this test, it's felt like they've gone through a marathon because they are making all the muscle spasms in their body. So when they come back, they could hurt. So be ready with acetaminophen or ibuprofen when they come back. So diagnosing these children, they're going to have that waddling gait. They'll be falling down because that muscle weakness is going on. Do you know what Gower sign is? This is what I do. Get on the floor, and you can't get up. So you walk up your legs to stand up. That's Gower sign because you can't just pull up yourself. So you just, as an old lady, you pull yourself up off your legs. Same thing. Kids, they're so weak, they have to do the same thing. This is the one with lordosis, that inward lumbar curvature on that one. And as I said, they're going to be some sort of mental, cognitively delayed of some sort. Now, there's no cure. It is genetic. So genetic counseling for the family, absolutely, especially if they're considering another child, because a male probably is going to have Duchenne. And do they want to have another child with Duchenne since they already have one? So what is our goal for this child? Well, it's progressive muscle weakness. So we need to keep the child as active as we can, keep them moving, keep them functioning, okay? Usually they die from heart failure or their phrenic nerve and diaphragm muscles stop working, and they usually die as teenagers. Guillain-Barré, not fun. I mean, Duchenne muscular dystrophy. So now Guillain-Barré. Guillain-Barré is a virus. They call it an infectious polyneuritis. They don't know what it comes from. Maybe an upper respiratory they had. They're not really sure. But kids ages about 4 to 10. I saw it in one adult. It was one of my supervisors that was working with me and ended up with a Guillain-Barré and admitted to our hospital. What happens with Guillain-Barré? All of a sudden, you're walking and now your feet feel numb. They feel tingly. You start tripping and maybe falling. So you got weakness in the lower extremities. As this disease travels ascending or upwards, so it starts from the feet and ascends up, all the nerves that it hits is going to numb them. So as it gets to the urine and to the bowels, you don't know if you can urinate. You don't know if you can move your bowels. That's something that happens. Then it goes up further and it hits your phrenic nerve. Now you're not breathing because now your phrenic nerve is paralyzed. So the big thing with Guillain-Barré is monitoring them for their respirations. So this child, if they come in suspecting of it, minimum, they're going to be on an O2 sat monitor, making sure they're breathing. Okay. Treatment. Well, if they're not breathing, they're going to need ventilation. And they'll be ventilated as long as that nerves are still up to here and still numb. What happens with Guillain-Barré? It sits there for a while. And we just do symptomatic treatment. We give them respiratory. We give them nutrition. We take care of their urine and their stool. We have them in the bed. We move them. And we wait and wait until all of a sudden it comes down. Now, all of a sudden your phrenic nerve starts to work. And now the nerves in your bowels and your bladder, you're starting to feel it. And you start to feel down. And now your feet are starting to move again and work right. So it ascends up, stops your breathing, and then it sits there, and then it goes away. Tetanus. Tetanus, you know, we have a tetanus shot today. We shouldn't have any, right? Well, sometimes we do. Depends on if we're going to be getting those immunizations or not. Tetanus is also called lockjaw. What it means is the jaw gets tight and the muscles strangulate your trachea so you can't breathe. It's basically lockjaw. It's because you've had a cut, a wound, a puncture, and tetanus has entered your body. So it starts out with this tenseness here in that neck area, and then it goes into laryngospasm, and then your respiratory muscles are gone. And now you need a ventilator and you need to be paralyzed with muscle relaxants because this tenseness in the neck is insanely painful. It's like choking you, okay? That's tetanus. So put them on one of those type of neuromuscular blockers. We're going to try to get that muscles relaxed, give them some sedation, and let them fight this tetanus infection. So we will be giving them the tetanus toxoid vaccine. We will be, injecting the wound. Let's see the bottom of the foot. We'll be cleaning it, soap, water, antibiotic ointment. Sometimes they even inject around it with a tetanus toxoid to take care of it. So tetanus, not only are you going to treat it with antitoxin, don't forget also that the wound also needs treatment. This is an extremely sick kid. As I said, you stop breathing, everything's tight, you're paralyzed, sedated, on a ventilator in the ICU. You need to monitor all the things you monitor on these patients: intake, output, monitoring electrolytes, and then taking care of the wound on the foot, giving them their tetanus as toxoids as they need. And as I said, muscle relaxants, relax that muscle. They don't need to be feeling how they're being choked. Now, botulism. Have any of you had an infant that was constipated and your grandma said, oh, give him a little bit of honey, give him a little bit of Caro syrup, that'll make them pass their stool? It's an old-fashioned thing. I've heard it before. It's a problem. How long has the honey been on the shelf or that Caro syrup been on the shelf? Is it sterilized? Or is it infected already? You got to be careful with honey and light or dark corn syrup. That's the Caro syrup stuff. Infants up to age 1 cannot touch this. They say actually age 2, you can start giving honey to kids, not before that. Again, what happens with this kid, it's more upper respiratory things goes on, and then it is respiratory paralysis. Again, same thing, you stop breathing. So we're going to be giving that botulism immune stuff going on. Again, intubated, nutritional support, and we're going to keep that child going until it dissipates and goes the other way. And then spinal cord injuries. That is the fracture of my little 15-year-old little boy. Can you see it there? That is angulated C5, C6 fracture. And that kid came back from it. And you could do that too. Just again, protect that neck, all right? We know spinal cord injuries happens from so many things. Sports, of course, I've seen a lot. Motor vehicles, yes. And then how about birth, pulling the neck out of the vaginal canal? Sometimes we get neck injuries, clavicle injuries, all of these things. So therapeutic management of spinal cord injuries. Just like that little boy at that baseball game, somebody said, no, don't touch him. Let's wait. They got the ambulance there, rescue there. They put him on a backboard and they immobilized him and got him to me. And then I was able to continue that immobilization and got that kid coming back and giving me a hug. I'll never forget him. So a progressive infantile spinal muscular atrophy and the most common of paralytic form of floppy infant syndrome. Do you remember the name? Wording Hoffman. Okay. Any questions? Jada, Ashley, are you with me? Thank you so much, Ashley. Jada, you there? Does anybody know Jada? Text her, tell her to come on. Thank you, Muntaz. I need you on too. All right, let's do a Kahoot. Who wants to win this one? You gonna do it again, Aaron? Maybe. You can. You worked hard for it. There's only 20 of them here, so this one isn't a long one at all. And then we'll be done for today. So remember, I've got all of your HESI stuff coming out at midnight tonight for you to go back to practice. I've got two 100 question Kahoots. Practice, 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 practice. And then visit me on my HESI Q&A and put it all together, and you guys will do okay on the HESI. If you do what I tell you, you'll be over 900, guaranteed. Right, Aaron? You do what I say, you'll get over 900? Yes, ma'am. Anybody else is coming? We're all half asleep on Friday afternoon. We've had a hole in it. All right, let's just get going. Let's get her done. Neuromuscular dysfunction, progressive muscle wasting. Goals for juvenile idiopathic arthritis includes again, what is juvenile idiopathic arthritis? It's the body attacks its joints, causing swelling and pain. So what is my goal? To stop it. Reduce joint pain and swelling. It's that easy. Don't overthink that. A multi. What might you anticipate for a child diagnosed with JIA? What would you see? Part of your assessment. Facial rash is lupus. Okay, but yes, joint disfigurement. Of course, anything with the joints, the hip joints get hit pretty hard. That's why the difficulty walking. And remember that redness, that uveitis is something specific to JIA, and they need to go be checked by ophthalmology about once a year. What is cerebral palsy? So, cerebral palsy is all about the muscles in your body and that there is problems with the movements and with that coordination. A multi-select. What are signs and symptoms of spastic cerebral palsy? So, when you have cerebral palsy, your body doesn't work the way it should, and usually you're mentally, cognitively, you are delayed. So, with that being said, cerebral palsy is about the muscles. So, you're going to have poor fine motor, poor gross motor skills, poor posture, hypertonicity, that tightness, that's in the spastic. And when you're so spastic, you cannot have your balance. That's why they need walkers and they need splints to help them stand there proper. A multi. When feeding a child with cerebral palsy, what is important to remember? Remember, there's a problem with muscles on these children. Whether it's a leg, an arm, or a jaw, it's still a problem with muscles, isn't it? So we need appliances for the muscles to work correctly. So if we're feeding them, we need to do all those things to help them eat the easiest as they can. Now, their muscles don't work the way that they should. So head of the bed elevated to prevent aspiration. You would have thick secrete liquids, not thin. They go down easier, less choking. just to let you know. Also, give the kid enough time to be able to chew and swallow. They will take extra time. Sometimes they need help with their jaw. And then sometimes they eat a little by mouth and then the rest goes down a G tube. But why not feed them if they can? It just takes extra time. They don't need to have a gastrostomy tube if they can eat. A myelomeningocele. So a myelomeningocele is when the spinal cord and the meninges, there's an open area and somewhere in the thoracic lumbar spine, and the meninges and the spinal cord are ripped up from the bottom and pulled out and are laying up on top of the lower back of this baby. So pulling of those nerves is what our big thing is and we're concerned about. And of course, we're worried about an infection here. So again, normal saline, sterile dressing, wet, dry, and keep the area tissue, good skin integrity. Okay. What can help a child with lupus erythematosus prevent exasperations? So the thing with lupus, actually sunlight can cause lupus. So if you have lupus, one of the things that you can prevent that feeling bad feelings is to prevent you from having too much sun, which is wearing sunscreen, which is also decreasing that exposure to sunlight when you can. And then they also, this is one that gets prophylactics, has nothing to do with diet and fat, has nothing to do with that. That's your things like celiac disease, right? That's cystic fibrosis. That's problems with fat, not this one. Infants with myelomeningocele demonstrate what? To remember, we've taken this big blob of meninges and spinal cord, it's ripped up and pulled out and out of the skin. And because it's pulled those nerves, there's going to be decrease in sensations from minimal to complete. So you don't know how much movement's going to be there. So there's going to be motor and sensory impairments of some sort. Myelomeningocele have decreased motor and sensations of the lower extremities. The nurse should monitor what really closely? So if I have decreased nerves in my lower extremities, what are things you need to worry about? You need to worry about urinary retention is something big. Also, constipation. Those two things could be dangerous if we let it go too far. Yes, we're going to be concerned about foot drop and skin breakdowns and contractures and all of that, but closely, we need to be monitoring urine and stool. Those are the two number one things. Yes, we're going to do all the other things, but first of all, it's that urine and stool that we'll be monitoring. A key feature of Duchenne muscular dystrophy is so this is a kid who is okay, and then all of a sudden starts stumbling and waddling and falling down, and progressively all the muscles in his bodies just stop working. And when the heart and the diaphragm starts, and that's usually about adolescent age, that's when they usually die. It's boys. What is one of the procedures that child with possible Duchenne's may need to diagnose this condition? So remember, this is a progressive muscle wasting. So we need to look at the muscles to see if they're deteriorating. How do we do that? There's this test called an electromyography. And what they do is they either put little needles or just like skin tabs, like you would for cardiac monitors. They put it on the arm, the leg, wherever they want to test the muscle, and they insert a shock. And this machine measures how quickly and how strongly did that shock attack that muscle and how did that muscle respond. And that's what it looks for. And again, remember, you have gone in and you've stimulated a lot of muscles in this child's body. And it's like they've ran a marathon. They're going to come back sore and expect it. Okay. So make sure they get some acetaminophen, ibuprofen, something to help them. How is Duchenne muscular dystrophy inherited? And it's from mom. It's X-linked recessive. Remember, if mommy wants to have another child and she's asking you what's the chances of having another child with DMD, you would say you need to go to genetics. You need to go get a genetic consult, and they need to tell you all the possibilities with it, okay? But mom does pass it on. Remember, it's boys. In caring for a patient with Guillain-Barré, the priority concern is what? What is Guillain-Barré? It's a viral something that happens, and it starts, the nerves just stop working. And it starts with the feet, and it ascends up until it hits that phrenic nerve and says, stop working. And then the diaphragm doesn't have a spark to make it breathe. So they stop breathing. So again, it's all about airway, monitoring airway, airway, airway. For patients suffering with Guillain-Barré, they would complain of weakness that was what? And we call it ascending because it starts from the feet and it ascends upwards until it hits the diaphragm. Okay. It's called ascending. A multi-select. Treatment for Guillain-Barré includes. What is Guillain-Barré? It's a polyneuritis caused by some sort of virus, they think. So, do we need antibiotics for a virus? No. So, heparin might be for prevention of DVT, but it's not treatment for Guillain-Barré specifically. Guillain-Barré, the treatment number one is a ventilator, respiratory support, and they think maybe to give some IV immunoglobulin, so extra, immune support, and maybe that will help. Maybe steroids. They're not even sure about that. I think it just takes time. And then all of a sudden you start to see that patient start to breathe, and then you start to see that numbness go descending all the way down, and then they start, being able to walk and go for physical therapy, et cetera, when they're done. What types of cerebral palsy causes hypertonicity and poor fine motor skills? It's my little Jonathan. It's that spasms. It is called spastic cerebral palsy. And usually when we talk about cerebral palsy and we're asking questions, we're talking more of that child who has more of that hypertonicity and problems with that movement. What priority action should a nurse take to a patient with a suspected spinal cord injury? So remember, with a spinal cord injury, your goal is to keep that neck in position so that you will not cause any further injury. Immobilize that spine. It's better to immobilize, take this kid to the backboard. So uncomfortable, but it's better to be safe. Do the x-ray, get the examination, and then take off that neck brace and off that board than it is to have spinal cord injury and be paralyzed for life. Who should get a tetanus? You should get a tetanus shot at how many years now? I've seen it change so many times. Tetanus shot. How many years in between doses? You know, when I first get tetanus shot, it used to be every 2 years. And then all of a sudden it went to every 5 years. And now it's every 10 years. And you know, they put diphtheria with it now. So now they're trying to also take care of that. So it's a double shot that you get with tetanus. And last question, what is a symptom of tetanus? I think tetanus, you know, the true and real case of it, the way that the tetanus attacks the muscles in the neck and basically squeezes and chokes this child. I think that is quite scary to me, and that is lockjaw. Remember, mostly these children get placed in ICU on um, neuromuscular blockers, you know, paralytic agents, so that we paralyze these muscles, let them relax, and time, and tetanus toxoids, antitoxoids, and remember, clean the wound because that's that entrance point. Let's see how we did. Number 3 is a jazz. Good job, Jazz. Number 2 is LV. Good job, LV. And number 1 is drum roll. Bing. We got an A again. Good job, A. And we have a blue and a salve and an MOUSC. So this is what I have for today. Remember, next week, come in. We're going to be taking your exam. Try to be in on time to a couple minutes early if you can. I know you're coming from, most of you, of communities to get you in checked in. When we're done next week, I'll be starting our HESI review, giving you information. I'm also going to send you the other classes. I have 2 big HESI reviews. I will make sure I'll do one for your class, one for the other class, so you'll have both recordings that you can go back and you can compare them, okay? And I'm sure that will help you with your essay. I am working on your assessments. I should be done by them this weekend. I want you to know that as I'm reading through them, I'm learning things, I'm seeing things. I've been shared personal stories, and it's been really rewarding. So I want to thank you to those who have put that into your work. Thank you. Any questions, anybody? I'll see you all next week, guys. Thank you.